I've always had this kind of romantic idea about medicine. It's like a Sherlock Holmes fantasy.
Oh, I know the one.
Yeah, you walk into a room, you see the patient, you spot one tiny obscure clue, a tremor or something, and snap, case solved.
All in under 45 minutes with commercials.
Exactly. But I have a feeling that's not quite how it works.
It's a nice image.
Yeah.
But, if you talk to any physician, they'll tell you the reality is just so much messier.
Yeah.
In medical school, we give students these perfect textbooks.
Right. Chapter 1, the thyroid. Chapter 2, the adrenals. All in neat bullet points.
But patients don't read the textbooks. They show up with symptoms that overlap, lab results that seem to contradict each other, and physiology that just will not behave.
And that messy, unpredictable reality is exactly what we're jumping into today. We're doing a deep dive into endocrinology and diabetes, case studies, questions, and commentaries.
And this isn't a textbook of definitions. It's more like a collection of, battle stories from practicing physicians. We're going to cover the common stuff, but also some of the absolute zebras.
The rare cases you might see once in a career.
Exactly.
So our mission here is to sort of act as a medical primer. We want to get under the skin, look at this whole interconnected web of hormones and glands, and really understand the why behind it all. We have to think like detectives.
That's the perfect framework. We're going to use a simple model, spot the clue, understand the physiology, and then, and this is critical, determine the management.
Because getting it wrong can be dangerous.
In endocrinology, if you misinterpret a biochemical clue, the treatment can sometimes be worse than the disease.
Okay, so let's start at the neck. The thyroid. It feels like the perfect place to start because thyroid issues are so common, but they can present in so many different ways.
It's the body's metabolic engine. It really just dictates speed. Too much hormone and everything races.
Your heart, your gut, your mind.
Everything. And too little and everything just crawls.
Yeah.
But the presentation is almost never that simple.
So let's take case 1 from the book.
Yeah.
We have a 31-year-old woman. She comes in with thyrotoxicosis.
So way too much thyroid hormone.
And she's got the palpitations, she can't stand the heat, and she has thyroid eye disease.
Okay, and that eye disease is a massive clue. A huge one. That specific look where the eyes seem to bulge out a bit, that almost guarantees we're dealing with Greg's disease.
Which is an autoimmune condition.
Right. Your own antibodies attack the thyroid, but instead of destroying it, they stimulate it.
Yeah.
It's like they hit the gas pedal and just tape it to the floor.
So the standard move is to block the hormone factory. They put her on a drug, carbamazole, but here's the twist. She didn't get better.
No, her biochemistry actually got worse.
And not only that, her goiter, the swelling in her neck, it grew while she was on the medication. How does that even happen?
Well, that's the key physiological insight here. The medication, it blocks the synthesis of the hormone. It stops the factory from making the product.
Okay.
But it doesn't stop the stimulation. Those antibodies are still just screaming at the thyroid to work harder. And here's the kicker. Because the medication is lowering the hormone levels in her blood, her brain, the pituitary gland senses that drop. So it starts pumping out TSH, thyroid-stimulating hormone, to try and help.
Wait, so the thyroid is getting hammered from 2 different sides?
Exactly. The autoimmune antibodies and the brain's own backup system. It's a double whammy of stimulation, and that causes the tissue to grow.
So this case just shows that Graves isn't a one-size-fits-all disease.
Not at all. Some people respond beautifully. Others, like this woman, have a process that's so aggressive that medication is basically a dead end.
So when the pills fail, you have to do something drastic.
You have to remove the target. And the editors talk about a total thyroidectomy. It's a definitive cure. You cut out the gland, you stop the toxicity immediately.
But then you're trading one disease for a lifelong dependency on replacement pills.
You are. But when a goiter is compressing the windpipe and the heart is racing out of control, it's really the only safe path forward.
Okay, let's swing to the complete opposite end of the spectrum, case 2. We're not talking feeling a little tired. We're talking about a coma.
Myxedema coma. It's rare, but it is one of the few true endocrine emergencies. The mortality is very, very high if you miss it.
The patient comes in with a reduced level of consciousness, and the detective work here is incredibly high stakes. The book points to 2 specific clues: a drop in the Glasgow Coma Scale and respiratory acidosis.
Let's unpack that respiratory acidosis because that's the one you absolutely cannot miss. Thyroid hormone drives the respiratory center in your brainstem. When your levels just plummet, your brain literally forgets to breathe deeply.
Because you start taking these shallow breaths.
Right. And that means carbon dioxide builds up in your blood.
And CO2 is a narcotic.
Exactly. High CO2 makes you sleepy. So the lack of thyroid makes you tired, the CO2 makes you sleepier, you breathe even less, CO2 goes up even more. It's a physiological death spiral.
The editors made a really interesting point about the tipping point, that you don't just slide into this, there's usually an accomplice.
That's the detective's job, find the trigger. You can walk around with severe hypothyroidism for months, just sort of functioning at a low level, but then you get an infection.
Yeah.
Or you're exposed to extreme cold.
Or take a sedative.
Yes. That extra stress pushes a really fragile system right over the edge. And if you just treat the thyroid, but you miss the underlying infection, the patient will likely die.
Wow. Okay, before we leave the thyroid, just a quick touch on case 3 with pregnancy, because the idea that pregnancy itself can mimic thyroid disease was fascinating to me.
Oh, it's a vital differential diagnosis.
Yeah.
And it all comes down to structural mimicry. In early pregnancy, the placenta makes a hormone called HCG.
That's what's in the pregnancy test.
That's the one. And structurally, HCG looks a lot like TSH. It's a case of mistaken identity. So at very high levels, HCG can actually bind to the thyroid and stimulate it.
And this is often linked to that severe morning sickness, hyperemesis gravidarum.
Yes. The higher the HCG, the worse the sickness, and the more thyroid stimulation. We call it transient gestational hyperthyroidism.
And the distinction is so important because the treatments are completely different.
Totally. For Graves' disease, you might need medication. But for the HCG effect, it's self-limiting. It goes away. You just need hydration and supportive care. You really want to avoid giving unnecessary drugs to a pregnant woman.
Okay, let's move up the map. To the brain, the pituitary, and then down to the adrenal glands. This is where the feedback loops get really complicated.
Master controllers.
Case 7 introduces a patient with galactorrhea and secondary amenorrhea.
Which is, in plain English, producing breast milk when you're not supposed to and your periods have stopped.
Which immediately points to the hormone prolactin.
Right. Prolactin is the milk hormone. But here's the cool part, the physiology that connects those two symptoms. From an evolutionary standpoint, if a woman is breastfeeding, it's not a great time to get pregnant again.
Nature is efficient.
Very. So high levels of prolactin send a signal to the brain to just shut down the ovaries. It inhibits a hormone called GnRH.
And no GnRH means no signal to the ovaries, no ovulation, no periods.
So the milk and the stopped periods are two sides of the same hormonal coin.
Now, usually you'd run a blood test, see super high prolactin, and you've got your diagnosis. A prolactinoma, a benign tumor. But the text warns about something called the hook effect.
It's real plot twist. It's a technical trap in the laboratory assay. Imagine you have a massive tumor just pumping out an ocean of prolactin.
Okay.
The test relies on two antibodies binding to the hormone to create a signal. Think of it like a sandwich.
But if there's too much hormone...
The system gets swamped. All the antibodies get used up binding to single molecules so they can't form the sandwiches. The machine gets confused and reads the result as low, or even normal.
That is terrifying. You have a patient with all the symptoms, but the lab says normal.
A lazy detective walks away. But a good detective says, wait, this doesn't match the clinical picture. And you have to call the lab and tell them to dilute the sample.
And once they water it down, the real massive number is revealed.
That's the hook effect.
And luckily for these tumors, we don't always need surgery.
No, we have dopamine agonists. These pills are incredible. They can shrink these tumors down to nothing. It's one of the few brain tumors we treat primarily with medication.
Speaking of tumors, let's talk about acromegaly, case 8. Excess growth hormone.
Acromegaly is so tricky because it's just so slow. It's insidious.
Yeah, the book says diagnosis is often delayed for years. Why do we miss it?
Because the changes are so gradual. Your jaw gets a tiny bit wider, your hands get a little puffier, you don't notice it day to day. It's that boiling frog analogy.
The book really emphasizes a specific kind of history-taking here, not just how do you feel.
No, it's practical questions. Has your shoe size changed? Do your rings still fit? And the most powerful tool of all, ask for an old photograph, a driver's license from 5 years ago. The change in facial structure just leaps out at you.
And it's not just the growth hormone itself doing the work, is it?
No, GH stimulates the liver to produce something called IGF-1. That's the worker bee that causes the tissue to grow, the headaches the patient had. That's just the tumor physically pressing on things inside her skull.
Let's drop down to the adrenal glands. Case 12, adrenal failure. This feels like the most urgent one in the book. Missing this is lethal.
Absolutely. This is Addison's disease. The patient comes in with weight loss and dizziness. I mean, really vague symptoms.
To be anything.
Could be stress, the flu, anything. But the smoking gun is in the blood work. The electrolytes.
Sodium and potassium. You're looking for low sodium hyponatremia and high potassium hyperkalemia.
Exactly. It's all about aldosterone, a hormone from the adrenals. Its only job is to tell your kidneys to hold on to salt and get rid of potassium. If your adrenals fail, you lose that hormone.
So you start peeing out all your salt and you can't get rid of potassium.
And the trap here is mistaking this for simple dehydration. A doctor sees a dehydrated patient and just gives fluids. But if you don't replace the missing steroids, hydrocortisone, their vascular system collapses.
So the dizziness isn't just feeling faint, it's their blood pressure crashing.
It's profound hypotension. So you have to recognize the pattern. Low sodium, high potassium, low blood pressure. That is Addison's until proven otherwise.
Okay, let's shift to diabetes. For most people, it comes in two flavors, right? Type 1 and type 2.
That's the binary view. But the source material just blows that wide open.
Okay, enter case 20, Jennifer. 20 years old. She gets sick. Her blood sugar is 27. Normal is, what, 5?
Yeah, 27 is incredibly high. And she has ketones. Her body is starving for fuel.
So young person plus high sugar plus ketones. That's a slam dunk for type 1. Here's your insulin, Jennifer.
And that's what 95% of clinicians would do.
Mm.
But the detective in this case paused because Jennifer was antibody negative.
She didn't have the immune markers for type 1.
And she was lean, so she didn't fit the type 2 profile either.
So if it's not type 1 and not type 2, what on earth is it?
MOY, maturity onset diabetes of the young.
That's a great acronym. It sounds friendly, but it's a genetic mutation.
It is a single broken gene. It's a coding error in the pancreas.
And this is why this matters. Does this just change the label, or does it change her life?
It changes her entire existence. Misdiagnose her as type 1, and she's injecting insulin multiple times a day for life. But certain types of MODY, specifically one called HNF1A-MODY, respond incredibly well to sulfonylureas.
Those are old, cheap pills.
Exactly. So she could potentially throw away the needles and just take a pill.
Yeah.
Because her pancreas can make insulin, it just needs a specific chemical nudge.
That is a massive, massive difference.
It is. And it just hammers home the theme. Don't just accept the label. If the patient doesn't fit the box, young, antibody negative, a strong family history, you have to think about genetics.
The book also mentions another variation linked to ethnicity. Case 21, an African woman with high sugar and ketones.
Right. Again, that presentation screams type 1.
Mm-hmm.
But she was also antibody negative. This is a phenotype we call ketosis-prone type 2 diabetes.
Which sounds like a total contradiction.
It does.
Yeah.
But it's well documented in sub-Saharan African populations.
Yeah.
They have this explosive onset looking just like ketoacidosis. But once you stabilize them, their beta cell function recovers.
So unlike a true type 1 diabetic, they can often come off insulin entirely.
Yes, and be managed with diet or oral meds. It's a humbling reminder that our standard definitions are often based on very specific populations.
Let's talk about the metabolic elephant in the room, obesity, cases 22 and 23. And I really appreciated that the editors didn't just say, eat less, move more.
That advice is, well, it's biologically reductive. Obesity is a complex physiological disorder. You have a woman who needs hip surgery but physically can't exercise, a truck driver with metabolic syndrome. The text forces us to look at the real barriers.
One thing that stood out was the vicious cycle of insulin. We treat type 2 with insulin, but
insulin is an anabolic hormone, a storage hormone. Its job is to store energy as fat. So you give a patient insulin, they gain weight. The weight gain increases their insulin resistance, so they need more insulin.
which causes more weight gain. It's a trap.
It is. And breaking that cycle needs modern pharmacology, like the GLP-1 analogs everyone is talking about now. They help break that anabolic cycle.
And for the most severe cases.
Bariatric surgery, which isn't a shortcut. It's a metabolic reset. It alters your gut hormones in a way that diet alone just cannot do for many people.
There was also a quick mention of men's health, the link between obesity and low testosterone.
Hypogonadism. It's a two-way street. Belly fat contains an enzyme that converts testosterone into estrogen.
So the more belly fat, the lower your testosterone.
And low testosterone makes it harder to burn fat. So treating the obesity often fixes the hormone deficiency on its own.
Okay, we have to talk about case 24. Severe hyponatremia. Low sodium. You said this scares doctors. Why?
Because of the brain. Sodium regulates water balance. If sodium drops too low, water rushes into brain cells and they swell. That causes seizures, death. But, and this is the terrifying part, If you correct the sodium too fast,
Something bad happens.
you strip the water out too quickly, it causes something called osmotic demyelination. You essentially strip the insulation off the nerves in the brainstem. It leads to locked-in syndrome.
The patient is awake but completely paralyzed.
And it is irreversible.
So the detective work is all about why the sodium is low. Is the body losing salt or holding on to too much water?
Depletion versus dilution. Exactly. You have to look at their urine. If the urine is concentrated but the blood is dilute, the body is hoarding water. That's SIADH. But if the urine shows they're just dumping salt, it's salt wasting.
And the treatments are opposite.
Complete opposites. Get it wrong, give fluids to an SIADH patient, and you could kill them. The stakes are the highest.
Let's finish up with reproductive endocrinology. Case 13, PCOS, polycystic ovary syndrome.
A very common condition. But the name is a bit misleading. You don't actually need cysts on your ovaries to have it.
The text calls it a diagnosis of exclusion.
Which means you have to prove it's not something else first. You can't just see irregular periods and acne and say PCOS.
Right.
You have to rule out thyroid issues, hyperlactin, and a tricky genetic condition called non-classic congenital adrenal hyperplasia.
What is that?
It's an enzyme defect in the adrenal glands that causes high testosterone. It looks exactly like PCOS. You have to measure a specific hormone, 17-hydroxyprogesterone, to tell them apart.
Once you've ruled all that out, what's the criteria?
The Rotterdam criteria. You need 2 out of 3 things. 1, irregular or absent ovulation. 2, signs of high androgens like acne. And 3, that polycystic look on an ultrasound.
So it brings us right back to the start. You can't just look at one symptom. You need the whole constellation.
That is the essence of endocrinology. It's all a system of feedback loops.
So, to wrap up, this deep dive really shows that medicine is structured detective work. You need observational skills, but you also need to understand the biochemistry to interpret the clues.
And you have to keep an open mind, like with Jennifer the diabetic or the woman with the normal prolactin. The obvious answer isn't always the right one. You have to follow the physiology.
All right, before we sign off, let's do a quick review exercise for our listeners. Test the detective skills.
Let's do it.
Okay, scenario 1. A young, lean patient has dangerously high blood sugar, but they're negative for type 1 diabetes antibodies. They have a strong family history of mild diabetes. What specific genetic type of diabetes should you consider before starting them on lifelong insulin?
Think back to Jennifer. The answer is MODY. Maturity onset diabetes of the young. You have to check for that genetic mutation.
Perfect. Scenario 2. A patient has weight loss, severe dizziness, and their labs show that classic pattern. Low sodium, high potassium. What's the can't-miss diagnosis there?
Remember the salt wasting. That is Addison's disease. You have to replace their steroids immediately.
If you got those, you're on your way to thinking like an endocrinologist.
We should end with a thought from the editors. They dedicated this book to mentors, trainees, students, patients, and families.
It's a lovely reminder, isn't it? We get so caught up in the TSH levels, the lab results, the genetic markers, but behind every single case study is a human being.
Right. The goal of all this detective work isn't just to solve the puzzle. It's to give someone their life back.
That's it for this deep dive. Keep asking questions, keep looking for clues, and we'll see you next time.